Good afternoon, everyone, and welcome to the National Coordinating Center for Public Health Services and Systems Research in Progress webinar series. I'm Anna Hoover. I'm the Deputy Director of the Coordinating Center, and I will be your moderator for the next hour for what promises to be a really interesting presentation and learning opportunity for us about the use of randomized control trials in public health services and systems research. You see the title on your screen, Adolescent AFIX, a multi-state randomized control trial to increase adolescent immunization through vaccine provider best practices. We have an exciting hour for you. I would like to point out before we get started that if you would like to download today's presentation, the project webpage from the PHSSR website, or speaker bios, they are available in the resources box on the upper right-hand side of your screen. In addition, as questions occur to you during the call, please make ample use of the chat box in the bottom right-hand corner of your screen. Enter your question there, and when we get to the Q&A session, we will be sure to get to as many as we possibly can. So I have just handled the welcome for today, and it is now my privilege to introduce to you our speaker. I will save the in-depth introductions of our commentators for a little later in the program, but our speaker today is Dr. Melissa Gilkey. Dr. Gilkey is an assistant professor of population medicine at Harvard Medical School and the Harvard Pilgrim Healthcare Institute. With research interests in adolescent health, cancer prevention, and health services research, Dr. Gilkey studies individual and organizational approaches to improving the delivery of adolescent vaccines with a special focus on the HPV vaccine. We're very happy to have Dr. Gilkey with us today, and we're looking forward to a terrific presentation. So with that, I will happily hand it over to you, Dr. Gilkey.
Well, thanks so much for having me. As Anna mentioned, today I'll be talking about the evaluation of an assessment and feedback approach to improving HPV vaccination. Before I get started, I'd like to take just a moment to acknowledge our study team, which at the University of North Carolina includes my co-PI, Noel Brewer, our project manager, Jen McKinnon, as well as Jennifer Lehman from the School of Nursing, who has graciously agreed to provide commentary today. We also have 3 great practice teams based at state health departments in Washington, Illinois, and Michigan. And we're lucky to have Nicole Frito, our team leader in Washington, on the call, and she will be providing commentary as well. So in terms of my plan for this presentation, I'd like to give a very brief overview of the problem of low HPV vaccination coverage in the U.S. and an introduction to the CDC's AFIX model of immunization quality improvement. I'll then discuss our ongoing RWJF-funded study, including our formative research findings and material development. And this presentation comes at a nice time. It's been a nice opportunity to kind of reflect on our PHSSR experience to date. And so I plan to wrap up by sharing some of what we consider to be our lessons learned in that regard. And I'd love to get some perspectives from others on the call on these. So this is an exciting time to be doing research related to HPV vaccination because in the past few years, the issue of increasing HPV vaccination rates has really emerged as a public health priority. From the CDC to the President's Cancer Panel to professional organizations like the American Academy of Pediatrics, there's this recognition that cervical cancer is a winnable issue. This is a puzzle that we can solve with technologies that we already have, including HPV vaccine. It's going to take some quality improvement work to make that happen. So let me start by reviewing the practice guidelines for the delivery of HPV vaccine. So what's the goal here? What's supposed to happen? HPV vaccine is a 3-dose series administered over a 6-month period, and routine administration is recommended for both male and female adolescents at ages 11 and 12. So with very few exceptions, all adolescents are meant to get the vaccine as preteens. If kids don't get doses at ages 11 or 12, they can get catch-up doses for females and men who have sex with men up till age 26, and for other males up to age 21. HPV vaccine is part of what's sometimes called the adolescent platform, and it's meant to be administered alongside 2 other vaccines for adolescents, tetanus, diphtheria, and acellular pertussis, or Tdap, and meningococcal vaccine. So despite these guidelines, we're unfortunately unlikely to see the full benefit of HPV vaccination in the U.S. because our coverage levels remain so low. And to see that, we can look at data from the National Immunization Survey. So this graph shows coverage over time for 3 vaccines in the adolescent platform, from top to bottom: Tdap, meningococcal, HPV vaccine for girls and for boys. And across that top in the black line, you can see the Healthy People 2020 goal for adolescent vaccines, which is for 80% coverage. So as of 2014, we've met that goal for Tdap, which is the top dashed line in the dark blue. And we're very, very close for meningococcal vaccine, which is that next line. But we have really a long way to go for HPV vaccines. So the red lines show series completion for girls, which reached 40% in 2014, and for boys, which reached just 22%. So what's at stake? Why does this matter? Well, the CDC estimates that failing to meet that 2020 goal means that today's population of 12-year-old girls will experience 53,000 cervical cancer cases over the course of their lifetimes that could have been prevented. Now, we're, of course, pretty good at detecting and treating cervical cancer, but 4,000 women still die of the disease each year. And even those who are successfully treated pay a price. They pay a price financially, emotionally, and physically. So we're really missing out on benefits in terms of mortality, but there are also substantial benefits in terms of morbidity. And we're also, of course, missing the opportunity to prevent other cancers and genital warts as well in both men and women. So if HPV vaccine is so great, what's the problem? Here's a conceptual model that my group uses to think about that question. So moving from right to left, in terms of behaviors, a provider recommending the vaccine, patient and parent accepting it, are the most proximal behaviors, and these are influenced by both psychosocial and systems level determinants, as well as the broader practice and policy environments. When you think about points for intervention in this model, you might assume that parents are the most obvious target. HPV vaccine, after all, has been the focus of a lot of very public controversy and continues to generate controversy. So I contributed an interview to a Boston Globe story just this past week about school entry requirements for HPV vaccination in Rhode Island that ran with the headline, "School Rule Targets Sex Disease." And stories like this would just have you believe that most parents are really up in arms, or just scared to death about HPV vaccination. But research really doesn't bear that out. So when you ask parents why they haven't gotten HPV vaccine for their children, the answers are not really very dramatic. So here are the main reasons parents of boys and girls report for not getting HPV vaccine as of 2013. Lack of knowledge, believing the vaccine isn't needed, not having gotten a recommendation, especially for boys. And you notice that these concerns are largely informational. So parents don't know enough, or they haven't gotten a recommendation. It's not always that they're just dead set against the vaccine. Concerns about safety and sex are there, but they really don't emerge as the main issues in either qualitative or quantitative. So parents are important, but the research literature really suggests that providers are even more important. So in this graph, you can see the percentage of vaccinated girls and boys comparing those whose parents reported getting a provider recommendation and those who did not. So for girls, there's a difference of about 20 percentage points. For boys, the difference is over 40 points. And this is just one of a couple of measures that suggest that providers have a lot of influence. The recommendation is really important. A recent meta-analysis suggests that parents who get a recommendation have about 18 times higher odds of getting their kids vaccinated compared to those who don't get a recommendation. So there just really is no more important factor than. Unfortunately, not all eligible adolescents get recommendations. So based on parental report, about a third of girls and over half of boys haven't received a recommendation. And we have some evidence to suggest that even when providers do deliver recommendations, they may not be recommending HPV vaccine as strongly as other vaccines. For example, we found that over 60% of providers say they prefer to recommend HPV vaccine as an optional vaccine for boys and girls. And you can imagine that this approach probably doesn't inspire a lot of confidence. So going back to our conceptual model, the available evidence suggests that if you want to improve HPV vaccination coverage, healthcare providers are the place to start. Provider recommendation is one of the strongest and most consistent predictors of HPV vaccination. And based on our model, intervening with providers means trying to improve their knowledge, attitudes, motivation, and skills. And it also means working to improve clinical systems that support adolescent vaccination. And so that's really where AFIX comes in. AFIX stands for Assessment, Feedback, Incentives, and Exchange, and it's a model of immunization quality improvement that was developed by the CDC. So AFIX is based on a process of assessment and feedback in which a quality improvement specialist, usually from a state public health department, visits primary care clinicians to share information about how the clinic is doing in terms of immunizing its patient population. So in the kind of bad old days, this usually meant pulling charts and calculating coverage estimates for the clinic. But these days, it's increasingly possible to use data from state vaccine registries to do this. So the specialist shares the coverage estimates and then may provide training to clinic staff as well as other resources to incentivize improved performance. After about 5 or 6 months, the specialist gets back in touch with the clinic to provide updated coverage estimates to let providers know whether or not their quality improvement efforts are working. Now, for early childhood vaccination, CDC recommends that state health departments provide AFIX consultations to a quarter of federally funded vaccine providers a year. So for young children, this is a quality improvement program that's already happening on a very big scale. Just a quick note on the theory. AFIX is informed by continuous quality improvement, or the CQI method, but I would say only very loosely informed. So obviously, in its ideal form, CQI involves rapid cycles of development in which you try out an innovation and then use data to see if it works, with the emphasis being on improving the process. And I would say that AFIX is definitely data-driven, and it does embrace that spirit of experimentation and collaboration. But where AFIX has usually differed from CQI is with the follow-up. So typically, clinics don't have continuous rapid cycles, but instead they get an AFIX consultation once a year or once every few years, which is really quite different from a pure CQI. So again, I always take care to say that AFIX is informed by CQI, not that it is CQI. We know that the AFIX process can work. So this slide shows the results of a meta-analysis conducted by the Community Preventative Services Task Force that looks at assessment and feedback as a way to improve vaccine coverage. And here we're looking at findings from 15 studies that examine coverage from a variety of vaccines, mostly early childhood vaccines, but some adult vaccines as well. And anything to the right of that vertical zero axis indicates a possible intervention effect. And we can see that most of the findings are on the right. So overall, the study suggested that assessment and feedback can improve vaccine coverage by about 10 percentage points. So in other words, it's an approach that can be really effective. That success raises the possibility of using assessment and feedback, and the AFIX model in particular, to improve adolescent vaccine coverage. So none of the studies in this meta-analysis looked at adolescent vaccines. But if assessment and feedback works for these other vaccines, why not HPV vaccines? We already have this program that's being implemented in all 50 states, like AFIX is. Why not use it for the vaccines that really need it? So that question inspired our collaboration with the North Carolina Immunization Branch. And together we designed a 3-arm RCT with 91 high-volume primary care clinics, in which clinics got an adolescent AFIX delivered in person in the traditional way, AFIX visit delivered by interactive webinar, or no AFIX visit for our control. And here we can see our main outcomes at 5 months. So in this graph, we see vaccine coverage changes by study arm for younger adolescents. And these bars represent the number of percentage points by which immunization coverage in each study arm improved for patients ages 11 and 12. The first bar in the cluster shows the control group, so that's the secular trend, followed by the in-person group. So this first cluster of bars on the left shows coverage change for Tdap. And we can see that the 2 intervention arms experienced changes that were about 4 points higher than the control. So we found that AFIX did have an impact on Tdap coverage. And there's a similar pattern there with regard to meningococcal vaccine. For HPV vaccine, we did find a statistically significant intervention effect, but it was smaller, so just 1.5 to 2 points over control. And that's perhaps not totally surprising. So we know that HPV vaccine isn't like meningococcal vaccine or Tdap. Improving HPV vaccine coverage really requires convincing providers to make recommendations more consistent. And so we likely need a somewhat different approach. Now, secondary study aim was to compare the intervention arms to each other, and as you would probably guess by looking at the graph, we didn't find evidence to suggest that the two delivery modes differed in terms of effectiveness. The webinars seemed to do just as well as in-person effects. So all in all, this was pretty good news. We would have liked to have seen more impact on HPV vaccination, but we did get some intervention effect, and we saw some evidence to suggest that webinar is a promising delivery. Unfortunately, an analysis that we conducted of outcomes at 1 year suggests that the improvements we saw at 5 months didn't last. So at 1 year, coverage for Tdap, meningococcal vaccine, and HPV vaccine was about the same across the three. So it seems that the intervention effect washed out. Another point of concern is that we found that AFIX didn't have an impact on older adolescents, ages 13 to 18, at either the 5-month or the 1-year time. So that brings us to the present study. We really felt like AFIX had potential for improving adolescent vaccination, but it had to work better and it had to work longer. And specifically, it really had to work for HPV vaccine, where the real need. So through RWJF, we were awarded funds for this study to use the AFIX model with the goal of improving HPV vaccine coverage specifically. And our main activities are to develop and test an improved AFIX consultation. And through an RCT with 270 primary care clinics, we're evaluating the longitudinal impact of AFIX on HPV vaccination coverage so that we can find out when the effectiveness of the intervention peaks and when its effect starts to wane. Like in our pilot, we're also comparing two modes of delivering AFIX consultations. So one study arm will consist of traditional in-person consultations, while the other will consist of consultations conducted by webinar. And Nicole will discuss this more in a bit later, but we think that webinar is really promising because state health departments are often very limited in the amount of travel they can do. Budgetary constraints, travel freezes, and just the logistics of sometimes having to cover very large geographic areas. At the same time, webinars can introduce challenges in terms of making connections with people and communicating. So we think that the delivery mode requires some evaluation. So where are we in this process? We're now finishing up year 2 of a 3-year grant, and at this point we have recruited study partners, conducted formative research, developed our intervention and training materials, piloted these materials, and started our RCT. I'll say a little bit about each of these. So first and most importantly in my mind, we recruited study partners in 3 state health departments, Washington, Michigan, and Illinois. And this recruitment process was a lot more intensive and complex than we had anticipated. All told, we had conversations with about 40 states, and we ran into some unexpected challenges that I'll talk more about. Our goal was to find 3 distinct practice environments in which to try out our intervention. And we've been incredibly fortunate to work with these 3 practice teams. And they are each really different. So in Washington, we're working in the context of a very well-established AFIX program with a high-functioning team and a relatively well-resourced team. Michigan also has a strong and long-standing AFIX program, but one that's shorter on staff and really resource-constrained. So we feel like this is an environment that probably reflects the reality of a lot of state health. Illinois is one of only a few states that has not had an AFIX program in recent years, but they have a strong interest and a strong commitment to establishing a program. So these 3 state partners really bring an opportunity to see not just whether AFIX works in general, but rather whether it can work across a range of practices. So once we recruited state partners, we conducted some formative research. We talked to our state partners. We talked with other states through our advisory board. We talked with our contacts at the CDC. And we also talked with some providers who received AFIX visits. I'd like to share a little bit about what we learned during this, how we responded in terms of our intervention development. So our first formative research finding was that AFIX visits vary. They vary a lot. So some states conduct fairly intensive, highly structured consultations, while others deliver visits that are very brief. The visits may be received by nurses, office managers, or medical assistants. And there's just not an AFIX formula. In some ways, this is good. And in some ways, it's probably not so good, particularly in the case of really minimal perfunctory visits. So in response to this finding, we did 2 things. First, we created a protocol or a manual for our intervention, which specified steps to conducting what we thought was a good AFIX visit, including suggested scripts and activities. We also developed a training guide that state health departments can use to prepare their AFIX specialists. So by manualizing our intervention in this way, we're aiming to establish grounds for assessing dose and efficacy. The second thing we learned is that physicians are typically not present for AFIX visits. So this was somewhat surprising because it was assumed by a lot of people, even at CDC, that physicians were involved. And for HPV vaccination, having physicians involved is critical because we really can't expect to move HPV vaccination coverage until we change providers' prescribing behavior. So in response, we made recruiting physicians and mid-level providers to be an explicit goal of our AFIX program. A related formative research finding is that the incentives states give for AFIX, so that's the I in AFIX incentives, are likely inadequate. We learned that it's just really hard to give incentives. It's hard to come up with the money to buy food, which could bring people together, but is increasingly not an allowable expense. And other incentives like plaques or other forms of recognition may only work with the providers who are already high performers. So one thing our key informants thought would be promising was to provide free CMEs to providers who participate in AFIX because these are pretty low cost rates, but they may be highly desirable to providers in terms of convenience. So in our study, we're trying this approach of offering free 1-hour CMEs for participating in vaccination. A fourth formative research finding was that even when providers see that they have low HPV vaccination coverage, even when you present them percentages, they don't necessarily recognize that as a problem. So the assumption is that low coverage is normal for HPV vaccine. There's just not all that much you can do about it. So in response to this finding, we've developed an immunization report card, which I'll show you in a moment, that's designed to communicate the problem of low coverage. We also created a PowerPoint presentation that can be used for academic data on HPV vaccination. And finally, we learned that AFIX is often overshadowed by other demands. And of course, we know this, but it's just one of those things that you can't hear too many times. So clinicians are incredibly, incredibly busy. In addition to the day-to-day demands of providing care, they face a lot of challenges related to staffing, moving to electronic medical records, and just other quality improvement initiatives. So to engage them in work of QI for HPV vaccination, we have to kind of take a hearts and minds approach. We have to make a strong case, and we likely need to communicate with them more regularly than through a single visit and follow-up session. So based on this finding, we developed an action plan that would help providers think about how to set a quality improvement goal and work toward it to make it feel more doable. We also put together a series of what we call email coaching messages that states can use to maintain contact with clinics over the 6-month QI period and give interim progress reports. So it's not just that you're getting your consultation and getting a final grade at the end, but that you get an interim report so that you know if you need to change course. And so using this approach, we hope to, our goal is really to bring AFIX just a little bit closer to that true CQI model and to prevent that washout of intervention effect we saw in the North Carolina pilot. So with this slide, I've tried to sum up what the practice-based products of our work will be, an intervention manual and a training guide, which include tools like an immunization report card, educational presentation for providers, and a mechanism for providing CMEs for participating. So next, I'd like to show you a few of our products, and one is the immunization report card that you can see here. The report card replaces a really cluttered and complex form that states typically use to share vaccination coverage with clinics. And it's meant to do 3 things: communicate the problem of low HPV vaccination coverage, set a measurable goal for improving coverage, and give specific steps that clinicians can take to reach their goal. So to take a closer look, here's the first section of the report card, which shows states the percentage of adolescent patients who have received each of the 3 vaccines in the adolescent platform. And in the standard and AFIX approach, you typically show clinics how they compare against state or national averages. And we purposely did not do that because our concern was that that would just normalize the idea of low coverage. Instead, we compare HPV vaccine coverage, which is typically low, to the coverage for the 2 other adolescent vaccines, which are typically high. So we're trying to set up a conversation that will be, you do a great job of vaccinating adolescents, but your HPV vaccine coverage needs were. In the second part of the report card, we set a goal for improving coverage. And this is different because in the traditional AFIX approach, clinics didn't necessarily have a goal. We asked them to try to immunize 10% of their adolescent patients in the 6-month study period. And instead of speaking in terms of coverage chains, we translate this into the actual number of patients. And we think that this will have more meaning for clinicians who deal in patients rather than coverage estimates, which is more a public health way of thinking about the problem. We also have boxes to share progress toward the goal at 3 and 6 months. So we've been excited because several states on our advisory board have already chosen to adopt this report card. And this is one of the things that's available on our project website for anyone who might be interested in taking a closer look at it, or even actually using it. So along with the immunization report card, we also have what we call a QI action plan, which helps states select strategies for meeting their QI goal and getting other members of the clinic on board. The CDC has gotten into this approach, and they've chosen to adopt AFIX going forward. That's been exciting as well. After developing our intervention materials, we came together with all of our state partners, pictured here, for a training session that included research presentations, practice presentations, and opportunities to actually practice delivering the intervention. And after doing a lot of work remotely by phone and by email, it was just a really great opportunity for us to all meet and spend time together. It really stands out for me as one of the high projects. After the training, each state piloted one in-person consultation and one webinar consultation, and then provided guidance for how to improve the intervention. So for example, our partners said that providers in clinics really want more information. They said, these are science nerds. They want more data. And in response, we really beefed up the more didactic component of our consultation. And that brings us to the RCT, which started in May. Our goal is for each state to deliver 30 in-person consultations and 30 webinar consultations so that we have a total of 90 clinics for each study condition. And as you can see, we're well on our way to getting there. We have 60 in-person consultations and 39 webinar consultations complete as of last week, and we're scheduled to finish recruitment by mid-October. So unfortunately, given our trial design, I can't yet say much about our findings, but I can share with you the components of our evaluation. So our primary outcome is change in HPV vaccine initiation or having one or more doses at 6-month follow-up. But we're also looking at coverage at 3, 9, and 12 months to understand how the impact of AFIX changes over time. These data will come from states' vaccine registries. To assess issues related to fidelity, we're conducting participant observations for a subset of our webinar sessions, and this has been a really great opportunity to explore how the intervention is adopted and adapted by each state. To understand how vaccine providers receive AFIX in terms of their satisfaction and engagement, we're conducting online surveys with clinicians at 3 time points, right before the visit, right after the visit, and at we're also studying the cost of delivering AFIX from the perspective of state health departments. We're lucky to be working with a health economist, William Callow, who's able to track resources devoted to the project using tools like Time. And finally, and perhaps most importantly, we meet with our state partners on a weekly basis by phone to get their feedback on how implementation is going. And we'll use these meeting notes to not only understand how the intervention works, but also to compile a list of key forms of technical assistance to accompany our training guide. So as I mentioned in the beginning of the presentation, I'd like to end by speaking to some of the challenges and facilitators of our work to date. And the first challenge has been understanding limitations in the capacity for state health departments to do this kind of work. When we went looking for funding for this project, we were very purposeful in budgeting a lot of our grant money for state health departments because we really wanted to be able to bring resources to support the work that states are doing. So through recruitment and through conducting the study, we've really come to realize that money is often the problem, but ironically, it's not always the answer. So states are often working under extreme constraints in especially in hiring, such that hiring a new staff person can take 2 years or more. Hiring temps may not be possible because of union contracts. Finding staff within a department may not be possible because everyone is just so overworked. And sometimes states just aren't administratively able to find a way to take the money. So that was really surprising to us, and it's been a big challenge, and that one that we continue to face. As Illinois, for example, has been through a state budget crisis and a budget freeze just in the past few months. A second challenge has involved working with states' vaccine registry data. And of course, any data source presents certain mysteries to be solved. And in this study, we have 3 very different systems, each with its own vendor, and each with its own set of strengths and weaknesses and surprises. A third challenge has been to try to preserve the light touch quality that makes AFIX feasible, while at the same time trying to ramp up the impact enough to really improve HPV vaccination. We've tried to do that through the email coaching and other strategies for involving providers without requiring them to physically be present, but it's been a really fine balance. And I would be remiss if I didn't also speak to the PHSSR facilitators. And the first and foremost of these has been our great partners at the state health departments, who are just really consistently smart and hardworking and creative in their problem solving. Again and again and again, when we've kind of come up against these bureaucratic problems, they found a way to overcome them. And they've also been very supportive of each other. So when one state experiences a problem, sometimes they contact us on the research team, and sometimes they just contact each other, and that's been really neat to see. Partners kind of share their strengths and their intellectual resources with each other, because while we on the research team may know how to study AFIX, they're really the ones who know how to do it, and for that reason, they're often a much better source of technical support and just kind of general know-how. And lastly, as I mentioned earlier, HPV vaccination has really emerged as a national priority in the last few years, and I think that's been a facilitator as well. We aren't just a lone voice in the wind anymore. Vaccine providers are really hearing the message about the importance of HPV vaccination QI from CDC through AAP and just a variety of sources. So again, it's a really exciting time to be doing this work. So with those thoughts, I'd like to conclude my portion of the presentation and turn to my colleagues for comment.
And I'll do a quick introduction. Thank you so much, Melissa, for that terrific presentation. I have seen in the last few minutes some folks who have started typing questions. In the lower right-hand corner of your screen is the chat box. Please do go ahead and enter those in, and we'll be getting to those in just a few moments. Our speakers following up on Melissa's presentation today are Dr. Jennifer Lehman, who is an assistant professor in the University of North Carolina School of Nursing. Dr. Lehman's research focuses on disseminating and implementing evidence-based interventions to promote healthy behaviors and prevent obesity and other chronic conditions. Dr. Lehman is a co-investigator on the study to which she lends her expertise in dissemination and implementation research. And following Dr. Lehman, we'll be hearing from Nicole Frito, who is the Provider Outreach Coordinator in the Office of Immunization and Child Profiles for the Washington State Department of Health. With extensive experience in implementing the AFIX program with Washington primary care providers, Ms. Frito is a study partner and has been closely involved in materials development and study implementation. I'd like to hand things over to Dr. Lehman first.
Thank you. I'm going to speak through the lens of dissemination implementation science. And it's widely recognized that simply disseminating evidence-based interventions or guidelines is insufficient to achieve their broad-scale adoption and implementation. And this is particularly true when implementation requires changes across multiple levels within complex systems, as is the case with adolescent vaccination and many other health challenges. Achieving broad-scale implementation of complex interventions requires additional, often ongoing support in the form of training, technical assistance, assessment and feedback, and ready-to-use tools. Abe Wandersman and his colleagues refer to this as innovation support. AFIX, therefore, is an example of an innovation support intervention. The AFIX consultation includes technical assistance, assessment and feedback, and tools. Many other organizations are providing innovation support. For example, in North Carolina, our area health education centers have nurses who provide technical assistance, data, feedback, and tools to support primary care's implementation of evidence-based intervention. Implementation support like that provided by the AFIX program holds great promise for promoting broad-scale implementation of evidence-based interventions, particularly in small clinical practices with limited capacity. Although there are lots of examples of innovation support interventions, the science of how to provide effective and efficient innovation support is just beginning to emerge. We recently completed and published a systematic review of innovation support interventions. In other words, interventions that provided training, technical assistance, and other supports with the goal of building capacity to implement evidence-based interventions. In our review, we found that authors provided very little information about the design or delivery of their innovation support. The absence of this type of information makes it difficult for others to replicate what they did or for reviewers to synthesize findings across studies and thereby build the evidence base for innovation support. Similarly, in-depth interviews with those providing technical assistance have found that they often view their role as vague and ill-defined. The AFIX project is exciting because it is advancing the science of how to provide innovation support that is both effective and also efficient. The project's team has taken great care in the design of its approach to technical assistance tools and performance feedback. The final product will include a detailed description of an effective approach to innovation support to improve vaccination in the form of details on the AFIX encounter content, medium, dose, and approach. They also are developing tools like the immunization report card. Study findings also will compare the effectiveness of two different approaches to delivery, an in-person approach and a web-based approach that has potential to be scalable and cost-efficient. I'll mention one final contribution of the AFIX project to the field of PHSSR. A lot of attention is being given to how we might better link public health and clinical practice as a means of building on the strengths of both, and the AFIX project illustrates one approach to linking public health and clinical practice. The AFIX project employs state-level public health staff to provide innovation support to clinics. In doing so, it builds on public health strength and population-level approaches to health improvements as a means of improving clinic-based care.
Thank you, Dr. Lehman. And now Nicole Frito.
Hi, everyone. This is Nicole. So for my comments today, I really wanted to build on the information that Melissa shared about the formative research findings and also the intervention components, and just how, what we've experienced delivering the actual intervention and how we think it may impact kind of the future of AFIX. So just to kind of start at the beginning a little bit, we wanted to participate in this study to determine how we could deliver more effective and efficient AFIX visits. And I really believe that we are identifying key components that will help us restructure how we deliver the AFIX program at the State Department of Health level. So just in terms of background about how we typically have done our AFIX visits, is we usually conduct them along with vaccines for children site visits, so or VSC, I'm going to call it for short. So VSC visits focus on making sure clinics meet federal requirements to get free vaccine for their patients who are under 19 years old. And we typically do these visits together in order to be more efficient with our time and also to really respect clinic staff time because their time is so limited, even a lot more than ours is. So we want to respect that. And so we try to do these visits together to minimize the times that we're actually contacting them at their offices. So, one of the things that with conducting the visits together, the downfall to that is that because AFIX is a quality improvement strategy, it gets less focus than the VSC or audit part of the visit, especially if the clinic has any findings that they have to correct. So I also wanted to mention that we have conducted some AFIX visits separately from VSC visits in the past. But one of the things we've experienced there, and we're also experiencing it with this study, is that it's a lot harder to schedule those visits because AFIX alone doesn't carry as much weight in the eyes of providers as a compliance or audit visit does. They know they're required to do a VFC visit, and they don't know or they don't really care as much about doing. So trying to schedule those visits alone is a lot more difficult than when we're trying to. One of the ways that that helps make the separate visits more feasible is to use webinars to cut down on travel costs and time. But there are also some drawbacks to using that particular method to deliver this intervention. At least in my own experience delivering this intervention for the study, it's a lot harder to engage with your audience and also read how they're reacting to the information. So that's one kind of thing I wanted to highlight as a downfall to webinars, but I still feel like it's an effective way to deliver the intervention. And it's just a lot more efficient for us, and I think it's really one of the few ways that it would be feasible to offer AFIX-only visits instead of combining them. So another thing I wanted to mention is it's been very difficult, even with offering continuing medical education credits, to get physicians to participate. We've not really had trouble getting, several MAs and nurses and a clinic or office manager to attend, but physicians are a lot harder. They may only, even if they do attend, they may only give you a few minutes of their time. So I think, what I've learned from that, at least doing this intervention, is that we need a different way to reach this audience instead of trying to engage them in the actual visit, because that may or may not be an effective way to reach them. They seem to respond especially well, though, to the report card and the educational slides and data on HPV disease and vaccine. Through this study, we've really been able to engage much larger groups of clinic staff at one time, and I believe that may be related to offering credits, but it also just may be that it's easier when you're offering an educational type program versus just quality improvement alone. It just may get more notice and more interest. We've had a really positive response overall to the intervention from the clinics that we've done visits with so far, especially related to the HPV-specific information. So clinic staff are typically really, they are grateful that we're there and providing that information. And I believe this means we need to add a stronger education component, especially with data, to our AFIX visits. And this would also allow us to have the benefit of offering continuing education. One of the things we've been noticing lately is that staff are really catching the key component of this intervention, which is to recommend the vaccine strongly starting at 11 years old. And that may or may not be something they're doing already, but they really are catching on to the importance of that, and they are deciding that they don't want to wait, or that they want to give the vaccine as early as 9 years old. Some of the clinics we visited just want education, but aren't as interested in quality improvement, or don't believe there's anything they can do differently, or they just believe it's not in their control to improve their vaccination coverage rates. And usually when we run into this, they're often blaming parents as, parents who are concerned about vaccinating their children, and they attribute their lower rates just to that, and that it's completely outside their control to do anything differently. It's really difficult to encourage and motivate clinics that have this type of view, but the approach that we've taken is just kind of gently try to persuade them to make little simple steps toward improvement, and you have to do a really good job of explaining why it's so important to improve. And a lot of the information that UNC developed with the slide set is able to do that. So it really supports us in providing a clear message to providers. One thing we've noticed too is that, especially for reaching physicians, that it may be best to deliver this intervention or even our typical AFIX visits and have a healthcare professional or maybe a health educator do that, because they have more credibility in the eyes of the provider. The standard slide set that we're using and the report card have been really helpful tools and would be a great approach to adopt for our AFIX program for the future. The report card is really well received, and it clearly helps clinics see the gaps in their HPV vaccination coverage when compared to the other vaccines like Tdap and meningococcal vaccine that are recommended at the same age. And it's much easier to explain this report card than the assessment reports we normally use for AFIX visits. So we're thinking that we may very well adopt this as part of our visits in the future, as long as it aligns with CDC requirements. One special challenge I really wanted to mention with this, because I think it has applicability in our normal everyday practice with AFIX too, is that right now clinics are really oversaturated with HPV information. It's really coming at them from all directions. So it's been really difficult to get clinics to schedule visits with us. You really have to do a good job identifying what's different about your program and really sell it to them, because otherwise you just kind of get lost in the shuffle. So if this study is successful at improving HPV vaccination coverage, it will really help all states improve the way that they deliver their AFIX visits, especially for HPV, but it may also apply to the AFIX visits that we do that are focused on childhood vaccines. So currently, our CDC guidance recommends that we do in-person AFIX visits. That's the preferred method. But if webinars show similar outcomes to in-person visits, this will give us leverage to encourage CDC to change the preference for in-person visits, and it will also open up the opportunity to be more creative in our approach and possibly do more visits per year in a more cost-effective and efficient way. It will be very helpful to have data, too, on how the intervention was received by clinic staff through the pre- and post surveys, because this will allow us to better gauge how clinicians' knowledge, attitudes, and behaviors changed after the visit, which, because AFIX is a very behavioral change or systems change-based program, that's really what we want to see as our outcome. It's a little bit harder to see changes in vaccination coverage, but if we can see behaviors change, that's a huge positive. Thank you.
Thank you, Nicole, and thank you, Jennifer. Again, I'm going to invite folks to type at the chat box. I've seen several questions started, but I haven't seen any submitted just yet. So please formulate your thoughts and drop those questions in the chat box. Oh, we have our first one. It is from Nathan, who says, first, great study. You have talked about the challenge of registry data. How are you ensuring that the registry data and the assessment algorithms are complete so that you are seeing the true rates and true change both within a state and across 3 states, or how are you addressing the data challenges? Thank you.
So I'll jump in here. This is Melissa. This is a great question because it has really been one of our main challenges. So part of it has just been working with each state to find out what it is that's being reported. So part of it is just a matter of kind of working with the data and getting to know the data. The other approach that we're using is to model coverage change instead of just having a point of coverage. And so by kind of in that way, we're trying to control for some of the noise that will inevitably be part of registry data, so that we're looking at change over time. And our goal is for, by using that approach, for that to account for what may be some blurriness in our denominator.
Thank you. I have a question while we're giving folks a chance to type some more. And my question is related to your evaluation component. I was really interested in how you're looking at fidelity, because as the folks on the line who do dissemination and implementation research know, there's always this tension between fidelity and local adaptation. Since the constraints, particular constraints and opportunities are often context-based, they might be accidents of geography or funding or organizational structure or governance, or so many things that feed into the specific conditions in which an intervention is implemented. And I'm curious from both an inputs and an outputs perspective with your participant observation of the webinars. I'm wondering if in terms of inputs you have a rubric or anything specific that you are providing to folks as they're watching the webinars happen in terms of assessing fidelity in that way, and if there's going to be any sort of an output from that, perhaps a qualitative assessment of where there were adaptations made that perhaps had not been planned, and then an ability to look at where those adaptations happened and if there were other kinds of changes that seemed to be in any way correlated with that. So again, my question is just about the fidelity piece on those participant observations. Do you have a rubric, and are you producing an analysis of that work?
Yeah, thank you so much for asking this question, because it is part of the evaluation that I'm especially excited about. We are using a protocol, a kind of standardized protocol to rate each visit. So we're having 2 people in the study team rate each of the webinar visits and then compare their scores across a variety of characteristics. And so that's kind of a somewhat quantitative component that we're then also going to pair with our state partners' reports about, how they conduct the visits and what they've had to change and what works for them and what doesn't. So kind of using those 2 sources of data, we hope to have a really rich understanding of how the intervention works in each of the different practice settings.
Thank you so much. That's really exciting to hear. I'm looking forward to reading that. We have, it looks like we have another question or 2 that are being formulated right now. So while that is happening, I would like to quickly remind folks about the tool that Melissa showed in her presentation, and that is available on the PHSSR website. If you are on this webinar online, you can download the project web page in the top right-hand corner of your screen, and that will help you navigate to the page where you can access that tool. But I think it's really interesting and valuable to have those kinds of tools available and to share them across the folks who are interested in this work. One question I have as we're waiting here, Melissa, is can you talk a little more about the randomization of the randomized control trial process? How did you sort of get in the weeds and develop that process and you start looking at how you're going to build out that set? I think that would be very helpful perhaps for some of the folks on the line to hear a little more about that process.
Sure, yeah. Well, we were able to use each state's immunization registry to come up with a list of eligible clinics. So clinics that were high volume clinics that had at least 500 adolescent patients. And so at that point, we just did a simple randomization by state. So we randomized clinics that were eligible using a 1-to-1-to-1 ratio. And then we've had, so our state partners have just used these lists and kind of gone sequentially down each list to try to recruit and enroll clinics. One interesting challenge has been that of geography. So for doing the in-person visits, it obviously doesn't make sense for someone to travel all the way across the state of Michigan one week and then to do that again the next week. And so we've kind of had to build in some wiggle room there so that states can cluster their visits to make sense for getting the travel done when they have to actually go to the primary care clinics to deliver the.
Excellent. That's very interesting, and I imagine that also is one of the ways that you were talking about the importance of providing some funding support to your state health partners, and I imagine that's a place where that has come in particularly handy.
Absolutely, yeah, and that has been a place where having funds available to support states has been, like you said, really, really helpful. Where it's been more challenging is that we'd also like to be able to support the time of our state partners, and that's just been a really unexpected and very challenging problem. In some settings that's worked out, and in ways it hasn't. Just something that we didn't expect. We thought if we brought the funding that that would kind of fix everything. And it just turns out that what states often need is person power, right? Like they need people to actually do the work.
Mm-hmm. Well, that leads us to Bill Brand's question here that is directly related to the funding issue. Bill says that given that increasing HPV rates have to occur in all 50 states, do you believe your best practices will be replicable without the extra funding you have found for the 3 project states?
Yeah, good question. I mean, we are thinking of our funding as in part supporting the research component of the of our study, which we've tried to keep to a minimum. But in terms of doing surveys, and our states are really doing the data collection for us, and so that becomes more burdensome than it would be in a practice setting. So a lot of the funding is for that purpose. CDC does provide packages of funding to each state, and so states are, they don't go so far as to say required, but they are, it's recommended by CDC that as part of their package of funding that grantees do these visits with a quarter of their providers each year. So states are already doing the visits, and we don't see these visits as being any more financially burdensome than other visits. And in fact, by if it turns out that webinar is a feasible approach, it could really, like Nicole said, increase the efficiency by quite a bit. And it has been funny to see, like I said, we talked to a lot of states, and some of them just had no interest in webinar at all. So we talked to, the New York City Health Department, and they were not at all interested in webinar. Their response was, well, we have subway cards, like we don't need webinar. But we also talked to other states like Hawaii or Montana, or these departments that are having to cover these huge geographic distances, and to them, webinar just sounded like that would be a miracle. So there is a, it's not that we think that this is going to be the right way for everyone, but if we can build in this flexibility, it could really be great for some states.
Terrific. And we have another question from our coordinating center, always interested in making sure that this important information and findings and materials that you guys are generating get shared as widely as possible. And Kelly would like to know when you all expect all the products, including the training guide, to be available for interested participants.
Absolutely, yeah. Well, there are certain components like the report card, like the QI action plan that are available now and that have been adopted already by other health departments. For the training guide and the implementation protocol, we would like to get through the end of the implementation phase of the RCT, which will be in October, get a final round of feedback from our state partners, and do some of our preliminary process evaluation, and kind of make one more round of edits. But I anticipate that those would be ready not far after that, I would say the spring for sure.
Excellent. Well, it falls to me now to thank again our terrific panel, Melissa Gilkey, Dr. Melissa Gilkey from Harvard Medical School, Dr. Jennifer Lehman from the University of North Carolina School of Nursing, and Nicole Frito from the Washington State Department of Health. It has been a pleasure to hear about this work and to hear from each of you today. We thank all of you for being online. I thank those of you who have listened in today, and ask that you share with us what you think about this PHSSR webinar series. We've been doing it for about a year now, going on a year, and we're looking to get feedback on how it's meeting your needs and if there are ways that we can improve it. Archives of all the webinars are available online at the URL you see here. And archives of all the webinars are available, again, there at that URL. The upcoming webinar, the next webinar on the docket is on Thursday, September the 17th, when we'll hear from Stan Finkelstein and Abigail Lauren Horn on modeling supply chain system structure to trace sources of food contamination. We have a number of additional upcoming webinars, as you can see on this slide, highlighting PBRN work, looking at infrastructure of local public health, looking at the cost of foundational public health services in Washington State. And we just heard from Ms. Frito there, so we have some more Washington connections coming down the pike. I want to thank you one more time for participating in today's webinar. Please be sure to tell us what you think about the webinar series, and join us at the publichealthsystems.org website for all of the information about these terrific projects that have been going on. Many thanks to Project Manager Ann Kelly, who has been working tirelessly to make this Research in Progress webinar series all that it can be. And we look forward to seeing you on the next call. Thanks so much and have a great day.